Varcarolis, Foundations of Psychiatric Mental Health Nursing, 8th edition, Chapter 15, Anxiety and Obsessive Compulsive Disorders. For most people, anxiety is a part of everyday life. I felt really nervous when I couldn't find a parking space right before my final exam. I know I would have done better if that hadn't happened. For some people, however, anxiety-related symptoms become severely debilitating and interfere with normal functioning. Today I got so worried I wouldn't find a parking space before the final exam, I stayed home. In this chapter, we will examine the concept of anxiety, defenses against anxiety, and an overview of anxiety and obsessive compulsive disorders, OCDs, and their treatment. Anxiety is a universal human experience and is among the most basic of emotions. It can be defined as a feeling of apprehension, uneasiness, uncertainty, or dread, resulting from a real or perceived threat. Fear is a reaction to a specific danger, whereas anxiety is a vague sense of dread related to an unspecified or unknown danger. However, the body reacts physiologically in similar ways to both anxiety and fear. Another important distinction between anxiety and fear is that anxiety affects us at a deeper level. It invades the central core of the personality and erodes feelings of self-esteem and personal worth. Normal anxiety is a healthy reaction necessary for survival. Without anxiety, our ancestors would have had little motivation to run from the saber-toothed tiger or hunt a mastodon. Anxiety provides the energy needed to carry out the tasks involved in living and striving towards goals. Anxiety motivates people to make and survive change. It promotes constructive behaviors such as studying for an exam, being on time for a job interview, preparing for a presentation, and working towards a promotion. An understanding of the levels and defensive patterns used in response to anxiety is basic to psychiatric mental health nursing care. This understanding is essential for assessing and planning interventions to lower a patient's level of anxiety, as well as one's own, effectively. With practice, you will become skilled at identifying levels of anxiety, understanding the defenses used to alleviate anxiety, and evaluating the possible stressors that contribute to increased levels of anxiety. Levels of anxiety. As discussed in Chapter 2, Hildegard Peplau had a profound role in shaping the specialty of psychiatric mental health nursing. She identified anxiety as a key element in her theory of interpersonal relationships. Peplau developed a useful anxiety model that consists of 4 levels: mild, moderate, severe, and panic. The boundaries between these levels are not distinct, and the behaviors and characteristics of individual experiencing anxiety can and often do overlap. Identification of a general level of anxiety is helpful in selecting interventions based on the degree of the patient's anxiety. Mild anxiety occurs in the normal experience of everyday living and allows an individual to perceive reality in sharp focus. A person experiencing a mild level of anxiety sees, hears, and grasps more information, and problem solving becomes more effective. Physical symptoms may include slight discomfort, restlessness, irritability, or mild tension-relieving behaviors, e.g., nail biting, foot or finger tapping, fidgeting. Moderate anxiety, as anxiety increases, the perceptual field narrows, and some details are excluded from observation. The person experiencing moderate anxiety sees, hears, and grasps less information and may demonstrate selective inattention, in which only certain things in the environment are seen or heard unless they are pointed out. The ability to think clearly is hampered, but learning and problem solving can still take place, although not at an optimal level. Sympathetic nervous system symptoms begin to kick in at this level. The individual may experience tension, pounding heart, increased pulse and respiratory rate, perspiration, and mild somatic symptoms, e.g., gastric discomfort, headache, urinary urgency. Voice tremors and shaking may be noticed. Mild or moderate anxiety levels can be constructive because anxiety may be a signal that something in the person's life needs attention or is dangerous. Severe anxiety. The perceptual field of a person experiencing severe anxiety is greatly reduced. A person with severe anxiety may focus on one particular detail or many scattered details and have difficulty noticing what is going on in the environment, even when another points it out. Learning and problem solving are not possible at this level, and the person may be dazed and confused. Behavior is automatic and aimed at reducing or relieving anxiety. Somatic symptoms, e.g. headache, nausea, dizziness, insomnia, often increase. Trembling and a pounding heart are common, and the person may experience hyperventilation and a sense of impending doom or dread. Panic is the most extreme level of anxiety and results in markedly dysregulated behavior. Someone in a state of panic is unable to process what is going on in the environment and may lose touch with reality. The behavior that results may be manifested as pacing, running, shouting, screaming, or withdrawal. Hallucinations or false sensory perceptions, e.g. seeing people or objects not really there, may be experienced. Physical behavior may become erratic, uncoordinated, and impulsive. Automatic behaviors are used to reduce and relieve anxiety, although such efforts may be ineffective. Acute panic may lead to exhaustion. See the case study and nursing care plan for panic level anxiety on the Evolve website. Review Table 15.1, which distinguishes among the levels of anxiety in regard to their 1. Effects on perceptual field, 2. Effects on problem solving, and 3. Physical and other defining characteristics. That table is the top half of the page, and you can look at that later. Defenses against anxiety. Sigmund Freud and his daughter Anna Freud outlined most of the defense mechanisms we recognize today. Defense mechanisms are automatic coping styles that protect people from anxiety and maintain self-image by blocking feelings, conflicts, and memories. Although they operate all the time, defense mechanisms are not always apparent to the individual using them. Adaptive use of defense mechanisms helps people lower anxiety to achieve goals in acceptable ways. Maladaptive use of defense mechanisms occurs when one or several are used in excess, particularly in the overuse of immature defenses. Figure 15.1 operationally defines anxiety and shows how defenses come into play. That figure is a nice little flowchart. We can look at that later. With the exception of sublimation and altruism, which are always healthy coping mechanisms, most defense mechanisms can be used in both healthy and unhealthy ways. Most people use a variety of defense mechanisms, but not always at the same level. Keep in mind that evaluating whether the use of defense mechanisms is adaptive or maladaptive is determined for the most part by their frequency, intensity, and duration of use. Table 15.2 describes defense mechanisms and their adaptive and maladaptive uses. And that table takes up an entire page. We can look at that later. Anxiety disorders. Individuals with anxiety disorders use rigid, repetitive, and ineffective behaviors to try to control their anxiety. The common element of such disorders is that those affected experience a degree of anxiety that interferes with personal, occupational, or social functioning. The presence of chronic anxiety disorders may increase the rate of cardiovascular system-related deaths. Anxiety disorders tend to be persistent and often disabling. Clinical picture. According to the APA, the term anxiety disorder refers to a number of disorders, including separation anxiety disorder, specific phobia, social anxiety disorder, panic disorder, agoraphobia, generalized anxiety disorder. A closely related set of disorders, anxiety, results in abnormal selective overattention or obsessions. These obsessive compulsive and related disorders include the following: obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania, hair pulling disorder, excoriation, skin picking, that's it. Separation anxiety disorder. Separation anxiety is a normal part of infant development that begins around 8 months of age, peaks about 18 months, and begins to decline after that. People with separation anxiety disorder exhibit developmentally inappropriate levels of concern over being away from a significant other. There may also be fear that something horrible will happen to the other person and that it will result in permanent separation. The anxiety is so intense that it distracts sufferers from their normal activities and causes sleep disruptions and nightmares. The separation anxiety is often manifested in physical symptoms such as GI disturbances and headaches. Recently, clinicians have begun to recognize an adult form of separation anxiety disorder that may begin either in childhood or in adulthood. Those who are the subject of the attachment, a parent, a spouse, a child, or a friend, may become alienated due to the constant neediness and clinginess. In fact, adults with this disorder often have extreme difficulties in romantic relationships and are more likely to be unmarried. Characteristics of adult separation anxiety disorder include harm avoidance, worry, shyness, uncertainty, fatigability, and a lack of self-direction. It is accompanied by a significant level of discomfort and disability that impairs social and occupational functioning and does not respond well to the most popular type of psychotherapy, CBT. This problem is typically diagnosed before the age of 18, after about a month of symptoms. The 12-month prevalence rates of separation anxiety disorder in children, adolescents, and adults is 4%, 1.9%, and 0.9 to 1.9%, respectively. It is most common anxiety disorder in children. Females are more likely to be affected. Environmental stresses such as significant loss through death of a relative or pet, separation from significant others, or a change in environment by moving or immigration can bring about symptoms of this disorder. A physical or sexual assault may also precede symptoms. There's also strong evidence that this illness is inherited genetically. In children, this severe form of separation anxiety is often seen with generalized anxiety disorder and specific phobias. In adults, a range of disorders commonly exists. They are depressive disorders, bipolar disorders, anxiety disorders, PTSD, OCD, and personality disorders. Specific phobias. A specific phobia is a persistent irrational fear of a specific object, activity, or situation and leads to a desire for avoidance or actual avoidance of the object, activity, or situation. Specific phobias are characterized by the experience of high levels of anxiety or fear in response to specific objects or situations such as dogs, spiders, heights, storms, water, blood, closed spaces, tunnels, and bridges. Characteristically, phobic individuals experience overwhelming and crippling anxiety when faced with the object or situation provoking the phobic response. Daily functioning is compromised, and phobic people go to great lengths to avoid the feared object or situation. A phobic person may not be able to think about or visualize the object or situation without becoming severely anxious. The life of a phobic person becomes more restricted as activities are given up so that the phobic object can be avoided. All too frequently, complications ensue when sufferers try to decrease anxiety through self-medication with alcohol or drugs. Consider the case of Daniel, who developed profound fear of elevators after being trapped in one for 3 hours during a power outage. As his fear and anxiety intensified, it became necessary for him to use only stairs or escalators. He obsesses about the possibility that he will be forced to use an elevator in social situations and avoids attending events where this may occur. It has reached a point where even going inside closets or small storage rooms is unbearable. This fear of enclosed spaces is called claustrophobia. Other common phobias are listed in Table 15.3. 12-month prevalence rates for specific phobias in children, adolescents, and adults are 5%, 16%, and 8% respectively. Females are affected twice as often as males. Negative and traumatic experiences with the feared object or situations lead to the fear. Phobic reactions tend to run in families. Having a first-degree relative with a specific phobia puts one at greater risk for having the same specific phobia. Few people are seen in healthcare settings for treatment of phobias. In general, they seek help for comorbid conditions, including major depression, anxiety, substance use, somatic symptom disorders, and dependent personality disorder. Social anxiety disorder, or SAD, also called social phobia, is characterized by severe anxiety or fear provoked by exposure to a social or a performance situation that can be evaluated negatively by others. Situations that trigger this distress include fear of saying something that sounds foolish in public, not being able to answer questions in a classroom, looking awkward while eating or drinking in public, and performing badly on stage. Whenever possible, people with SAD avoid these social situations. If they are unable to avoid them, they endure the situation with intense anxiety and emotional distress. Small children with this disorder may be mute, nervous, and hide behind their parents. Older children and adolescents may be paralyzed by fear of speaking in class or interacting with other children. The worry over saying the wrong thing or being criticized immobilizes them. Conversely, younger people may act out to compensate for this fear, making an accurate diagnosis more difficult. This anxiety often results in physical complaints to avoid social situations, particularly school. Fear of public speaking is the most common manifestation of SAD. Interestingly, this disorder has afflicted famous singers and actors such as Barbra Streisand and Sir Laurence Olivier, both of whom were terrified that they might forget the words to songs and scripts. The 12-month prevalence of SAD is the same for children, adolescents, and adults, about 7%. As with many of the anxiety disorders, females are more likely to be affected. Risk factors for SAD include childhood mistreatment and adverse childhood events. The trait of shyness is also strongly heritable. Having parents who are shy carries a double risk of genetic transmission and parental modeling. Chronic social isolation may increase the risk for major depression. Substance use disorders are common and may be related to the social isolation and inhibition of the illness. Bipolar disorder and body dysmorphic disorder are also comorbid. In children, comorbidities include high-functioning autism and selective mutism. Panic disorder. Panic attacks are the key feature of panic disorder. Panic attack is a sudden onset of extreme apprehension or fear, usually associated with feelings of impending doom. The feelings of terror present during a panic attack are so severe that normal functioning is suspended, the perceptual field is severely limited, and misinterpretation of reality may occur. People experiencing panic attacks may believe they are losing their minds or having a heart attack. Typically, panic attacks come out of the blue, i.e. suddenly, and not necessarily in response to stress, are extremely intense, last a matter of minutes, and then subside. Unpredictability is a key aspect of panic disorder in children and adolescents. The attacks of panic seem to come out of nowhere, last about 10 minutes, and then subside. During the attack, the young person is less able to articulate the psychological aspects, such as fear. They may become avoidant of situations where help is not available, may develop feelings of hopelessness in controlling these attacks, and may become depressed. Alcohol or substance abuse is not uncommon in adolescents with this disorder. People who experience these attacks begin to fear the fear. They become so preoccupied about future episodes of panic that they avoid what could be pleasurable and adaptive activities, experiences, and obligations. Major depression may occur before the onset of panic disorder or may occur at the same time. Substance use disorder frequently accompanies panic disorder, probably as attempts to self-medicate. Non-psychiatric disorders are also comorbid. They include hyperthyroidism, dizziness, cardiac arrhythmias, asthma, COPD, and IBS. Table 15.4 outlines a generic nursing care plan for panic disorder. The DSM-5 box contains diagnostic criteria for panic disorder. I'm going to go ahead and read that. DSM-5 criteria for panic disorder. A. Recurrent unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes and during which time 4 or more of the following symptoms occur. Note, the abrupt surge can occur from a calm stage or an anxious state. 1. Palpitations, pounding heart or accelerated heart rate. 2. Sweating. 3. Trembling or shaking. 4. Sensations of shortness of breath or smothering. 5. Feelings of choking. 6. Chest pain or discomfort. 7. Nausea or abdominal distress. 8. Feeling dizzy, unsteady, lightheaded, or faint. 9. Chills or heat sensations. 10. Paresthesias, numbness or tingling sensations. 11. Derealizations, feelings of unreality or depersonalization, being detached from oneself. 12. Fear of losing control or going crazy. 13. Fear of dying. Note, culture-specific symptoms, e.g. tinnitus, neck soreness, headache, uncontrollable screaming or crying, may be seen. Such symptoms should not count as one of the 4 required symptoms. B. At least one of the attacks has been followed by 1 month or more of one or both of the following. 1. Persistent concern or worry about additional panic attacks or their consequences, e.g. losing control, having a heart attack, or going crazy. 2. A significant maladaptive change in behavior related to the attacks, e.g. behaviors designed to avoid having panic attacks, such as the avoidance of exercise or unfamiliar situations. C. The disturbance is not attributable to the physiological effects of a substance, e.g. a drug of abuse or medication, or another medical condition, e.g. hyperthyroidism or cardiopulmonary disorders. And D. The disturbance is not better explained by another mental disorder, e.g. the panic attacks do not occur only in response to feared social situations, as in SAD, in response to circumscribed phobic objects or situations, as in specific phobia, in response to obsessions, as in OCD, in response to reminders of traumatic events, as in PTSD, or in response to separation from attachment figures, as in separation anxiety disorder. Agoraphobia. The term agoraphobia is derived from the Greek agora, open space, and phobia, fear. It refers to intense, excessive anxiety or fear about being in places or situations from which escape might be difficult or embarrassing, or in which help might not be available. The feared places are avoided in an effort to control anxiety. Situations that are commonly avoided are being alone outside, being alone at home, traveling in a car, bus, or airplane, being on a bridge, and riding an elevator. These situations may be made more tolerable in the company of another. Avoidance behaviors can be debilitating and life-constricting. Consider the effect on a father whose agoraphobia renders him unable to leave home and prevents him from seeing his child's high school graduation. Nearly 2% of adolescents and adults experience agoraphobia in a given year. Some children may develop this, but it typically begins in late adolescence or early adulthood. The ratio of females to males with agoraphobia is 2-to-1. Adverse childhood events and stressful life events are associated with the development of agoraphobia. Families of origin are often described as emotionally cool and overprotective. Genetics are also implicated in this disorder. Agoraphobia has a strong heritability factor of 61%. Before the onset of this fear-based disorder, many individuals will experience other anxiety disorders such as phobias, panic, and social anxiety. After the onset of agoraphobia, individuals often experience depressive disorders and alcohol use disorder. Generalized anxiety disorder, or GAD. The key pathological feature of GAD is excessive worry. Children, teens, and adults may experience this worry, which is often out of proportion to the true impact of events or situations. Common worries in generalized anxiety disorder are inadequacy in interpersonal relationships, job responsibilities, finances, and health of family members. Because of this worry, huge amounts of time are spent in preparing for activities. Putting things off and avoidance are key symptoms and may result in lateness or absence from school, or employment and overall social isolation. Family members and friends are overtaxed as the person with this disorder seeks continual reassurance and perseverates about meaningless details. Sleep disturbance is common because the individual worries about the day's events and real or imagined mistakes, reviews past problems, and anticipates future difficulties. Fatigue is a noticeable side effect of this sleep deprivation. The 12-month prevalence rate of GAD is nearly 1% in adolescents and nearly 3% in adults. Over a lifetime, the risk of this disorder is 9%. The ratio of affected females to males is 2 to 1. Parental overprotection and adverse experiences are associated with anxiety disorders. Genetics account for 1/3 of the risk for developing GAD. This anxiety problem is often comorbid with major depressive disorder. Other anxiety disorders frequently accompany generalized anxiety disorder. Refer to Table 15.5 for a generic care plan for generalized anxiety disorder. The DSM-5 box contains diagnostic criteria for GAD. Here we go, DSM-5 criteria for GAD. A. Excessive anxiety and worry, apprehensive expectation, occurring more days than not for at least 6 months, about a number of events or activities such as work or school performance. B. The individual finds it difficult to control the worry. C. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms having been present for more days than not for the past 6 months. Note, only one item is required for children. 1. Restlessness or feeling keyed up or on edge. 2. Being easily fatigued. 3. Difficulty concentrating or mind going blank. 4. Irritability. 5. Muscle tension. 6. Sleep disturbance. Difficulty falling or staying asleep or restless, unsatisfying sleep. D. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. E. The disturbance is not attributable to the physiological effects of a substance, i.e. a drug of abuse, medication, or another medical condition such as hyperthyroidism. F. The disturbance is not better explained by another mental disorder, e.g. anxiety or worry about having panic attacks and panic disorder, negative evaluation in social anxiety disorder, contamination or other obsessions in OCD, separation from attachment, blah, 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 we know all that other stuff. Other anxiety disorders. Selective mutism is a condition where children do not speak due to fears of negative responses of evaluation. They tend to speak at home around immediate family members. When engaged in activities that do not require speech, these children seem comfortable. Substance-induced anxiety disorders characterized by symptoms of anxiety, panic attacks, obsessions, and compulsions that develop with the use of a substance, e.g. alcohol, cocaine, heroin, and hallucinogens. In anxiety due to a medical condition, the individual's symptoms of anxiety are a direct physiological result of a medical condition, such as hyperthyroidism, pulmonary embolism, or cardiac dysrhythmias. To determine whether the anxiety symptoms are due to a medical condition, a careful and comprehensive assessment of multiple factors is necessary. Refer to Table 15.6 for a list of medical disorders that may contribute to anxiety symptoms. We can look at that later. OCD. OCD are a group of related disorders that all have OCD characteristics. Obsessions are defined as thoughts, impulses, or images that persist and recur so that they cannot be dismissed from the mind even though the individual attempts to do so. Obsessions often seem senseless to the individual who experiences them, ego dystonic, and their presence causes severe anxiety. Compulsions are ritualistic behaviors an individual feels driven to perform in an attempt to reduce anxiety or prevent an imagined calamity. Performing the compulsive act temporarily reduces anxiety, but because the relief is only temporary, the compulsive act must be repeated again and again. Although obsessions and compulsions can exist independently of each other, they most often occur together. Examples of common obsessions and compulsions are given in Table 15.7. OCD. OCD behavior exists along a continuum. Most sufferers may experience mildly obsessive compulsive behavior, such as nagging doubts as to whether a door is locked or the stove is turned off. These doubts require the person to go back and check the door or stove. Mild compulsions about timeliness, orderliness, and reliability are valued traits in U.S. society. At the pathological end of the continuum is OCD, with symptoms that occur on a daily basis and may involve issues of sexuality, violence, contamination, illness, or death. Pathological obsessions or compulsions cause marked distress to individuals who often feel humiliation and shame regarding these behaviors. The rituals are time-consuming and interfere with normal routines, social activities, and relationships with others. Severe OCD occupies so much of the individual's mental processes that the performance of cognitive tasks is impaired. English soccer player David Beckham has shared his struggle with OCD. He has a compulsion to count his clothes and line his magazines up in a straight line. The 12-month prevalence of OCD is 1.2%. Females are slightly more affected, but males have an earlier age of onset, about 25% before age 10. Onset after age 35 is rare. Sexual and physical abuse in childhood or trauma increases the risk of this disorder. Some children develop OCD along with a post-infectious autoimmune syndrome. Genetics are strongly associated with this disorder. First-degree relatives have twice the risk. Early onset OCD results in a 10 times greater risk than first-degree relatives. OCD tends to occur along with anxiety disorders 76% of the time. Other comorbid conditions for OCD include major depressive disorder, bipolar disorder, and eating disorders. About 30% of individuals with this problem also have a tic disorder. See the DSM-5 box for diagnostic criteria. DSM-5 criteria for obsessive compulsive disorder. A. Presence of obsessions, compulsions, or both. Obsessions are defined by 1 and 2. 1. Recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. 2. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action, i.e., by performing a compulsion. Compulsions are defined by 1 and 2. 1. Repetitive behaviors, e.g. hand-washing, ordering, checking, or mental acts, e.g. praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. 2. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. Note: young children may not be able to articulate the aims of these behaviors or mental acts. B. The obsessions or compulsions are time-consuming, e.g. take more than 1 hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. C. The OCD symptoms are not attributable to same stuff at the end of all of these DSM-5s. Okay. Body dysmorphic disorder. BDD was first described over a century ago and continues to be a challenge to treat. Patients with BDD are commonly seen in community, psychiatric, cosmetic surgery, and dermatological settings. Although patients tend to have a normal appearance, their preoccupation with an imagined defective body part results in obsessional thinking and compulsive behavior, such as mirror checking and camouflaging. In BDD, Levels of insight vary. People may be well aware that their thoughts are distorted, or they may be completely sure about existence of the defect. False assumptions about the importance of appearance, fear of rejection by others, perfectionism, and conviction of being disfigured lead to overwhelming emotions of disgust, shame, and depression. Patients are frequently concerned with their skin, hair, nose, stomach, teeth, weight, and breast or chest. Men tend to be concerned with body build and the appearance of their genitals and body build. Women focus on the appearance of their skin, stomach, weight, breasts, buttocks, thighs, legs, hips, and toes. Often the patient keeps the disorder secret for many years. The disorder is chronic and response to treatment is limited. Suicide risk is high in this population. The prevalence of body dysmorphic disorder is slightly higher in females, 2.5%, than males, 2.2%. The rate of this problem is higher among patients seeking cosmetic surgery, dermatology treatment, adult orthodontia, and oral/maxillofacial surgery. Individuals with this disorder often come from homes with abuse and neglect. Body dysmorphic disorder seems to be related to OCD because first-degree relatives often share those conditions. The most common comorbid disorder is major depressive disorder, which usually comes on after body dysmorphic disorder. SAD, OCD, and substance use disorders are also seen along with this disorder. Hoarding disorder. Have you ever reached a point where there is just too much clutter in your closet and you proceed to sort through it and make stacks to keep, give away, and donate? You probably have. And for most of us, this is neither a pleasant nor painful experience. For individuals with hoarding disorder, this purging would have been extremely distressing. In fact, the accumulation of belongings that may have little or no value prevents some people from leading normal lives. Belongings literally fill every available surface and area in the residences, and guests can or will no longer visit. The problem may progress to the point where the home is nearly uninhabitable due to unsafe and unsanitary conditions. Individuals who hoard may or may not be aware of the problem and how the quest to collect has consumed their lives and alienated others. It is difficult to determine the age of onset for this disorder, as children do not have the means to add to their collections as adults do. Symptoms usually emerge in adolescence, begin to interfere with functioning in the 20s, and significantly impair functioning in the 30s. The condition worsens with each decade of life. While more women are treated for hoarding disorder, it is likely that men are affected at much the same rate, but do not seek treatment for this problem. Estimates of prevalence from the United Kingdom are about 1.5%. Indecisiveness is associated with hoarding. Stressful life events seem to precede the onset of symptoms. The disorder is strongly heritable with a twin concordance rate. Percentage of time one twin will be affected when the other is of 50%. Nearly all hoarders, 75%, also experience major depressive and or anxiety disorders. Not surprisingly, about 20% of this population also has OCD. It is the presence of these other disorders that may cause these individuals to get treatment because they resist seeing hoarding as a problem. Trichotillomania and excoriation disorder. Trichotillomania, or hair pulling disorder, and excoriation disorder, or skin picking disorder, are two distressing problems that may result in varying degrees of disability, social stigma, and altered appearance. Both of the activities are irresistible to the individual, who typically tries to hide the activity. These disorders have been linked to symptoms of OCD. It occurs more often in children than adults and may begin as early as 1 year of age. Trichotillomania, it's really fun to say, may be one of the oldest recorded psychiatric problems. The phrase, "I was so annoyed that I wanted to pull my hair out," attests to the anxiety-related component of the disorder. Typically, it is the hair of the head but it may come from anywhere on the body, including eyebrows, eyelashes, pubic area, axilla, and limbs. The amount of hair removed ranges from small patches to complete baldness. For some, the pain brought on by hair pulling results in anxiety reduction, similar to those who engage in cutting. Most individuals may be unaware of the behavior until they notice a wad of hair close by. Trichophagia, or secretly swallowing the pulled hair, is common in this disorder. The ingestion may lead to hair masses or trichobezoar in the GI system. The masses can be fatal if they progress to abdominal obstruction or perforation. You may be interested to know the masses of digested hair are also referred to as Rapunzel syndrome. The disorder may begin in childhood, adolescence, or even adulthood and may last weeks to decades. 12-month prevalence in adolescents and adults is about 2%. Females are affected more frequently than males, with a ratio around 10 to 1. There is no gender difference in children. Interesting. The disorder seems to run in families. Individuals with relatives who have OCD tend to have higher rates of trichotillomania. People who obsessively pull their hair also often have major depressive disorder. Trichotillomania is often accompanied by excoriation disorder. The skin picking of excoriation disorder is typically confined to the face, although other areas of the body may be targeted. As with hair pulling, the individual may engage in skin picking as a means to deal with stress and relieve anxiety, while others may engage in this activity without thinking about it. Most people occasionally pick at their skin, nails, and scabs. However, people with skin picking disorder damage their skin. Fingers and fingernails are the usual implements. Biting, nail cutters, and tweezers are also used. The most common areas of focus are the face, head, cuticles, back, arms, and legs, and hands and feet. Complications include pain, sores, scars, and infections. The lifetime prevalence of this problem is 1.4%. 75% of those affected are females. The onset is in adolescence and frequently begins with conditions such as acne. A risk factor for this disorder is having relatives with OCD. Excoriation disorder is often accompanied by OCD and trichotillomania. Other compulsive disorders. Substance-induced OCD and related disorders are characterized by obsessions and compulsions that develop with the use of a substance or within a month of stopping use of the substance. Drugs used to treat the movement disorders and Parkinson's disease have been recorded to cause obsessions with gambling, irresistible urges for sex, and out-of-control spending. Wow. This diagnosis is based on a thorough history, physical examination, and laboratory findings. In OC or related disorders due to a medical condition, the individual symptoms of obsessions and compulsions are a direct physiological result of a medical condition such as post-encephalitic syndrome, post-anoxic event, traumatic brain injury, Huntington's disease, seizures, and cerebral infarctions. To determine whether the symptoms are due to a medical condition, a careful and comprehensive assessment of multiple factors is necessary. Evidence may be present in the history, physical examination, or laboratory findings for this diagnosis. Risk factors. There is no longer any doubt that biological factors predispose some individuals to pathological anxiety states, e.g. phobias, panic attacks. By the same token, traumatic life events, psychosocial factors, sociocultural factors are also etiologically significant. Biological factors, genetic. Numerous studies substantiate that anxiety disorders tend to cluster in families. Genetic variants have been identified that are associated with increased risk for anxiety and OCD. Twin studies demonstrate the existence of a genetic component to both panic disorder and OCD. First-degree biological relatives of those with OCD or phobias have a higher frequency of these disorders than exists in the general population. Neurobiological. The amygdala plays a role in anxiety and OCD. The amygdala alerts the brain to the presence of danger and brings about fear or anxiety to preserve the system. Memories with emotional significance are stored in the brain and have been implicated in phobic responses such as fear of snakes, heights, or open spaces. Certain anatomic pathways, e.g., the limbic system, provide the transmission structure for the electrical impulses that occur when anxiety-related responses are sent or received. Neurons release chemicals, i.e., neurotransmitters, that convey these messages. The neurochemicals that regulate anxiety include epinephrine, norepinephrine, dopamine, serotonin, and GABA. The jury is still out on the role of serotonin in anxiety disorders. Because SSRIs increase neural serotonin, researchers have assumed that low levels of serotonin are at least partially to blame for anxiety symptoms. Recently, Frick and colleagues discovered that serotonin in one anxiety problem, social anxiety, was actually elevated in the amygdala. This finding calls into question the role of SSRIs in improving anxiety symptoms. GABA, an inhibitory neurotransmitter that puts a brake on excitatory neurotransmitters, is commonly the focus of pharmacological therapy for anxiety symptoms. GABA slows neuron activity, which plays a role in lowering anxiety. It is believed that people with too little GABA may suffer from anxiety disorders. Psychological factors. Psychodynamic theory suggests that unconscious childhood conflicts are the basis for future symptom development. Sigmund Freud posited that anxiety results when threatening repressed ideas or emotions are close to breaking through from the unconscious mind into the aware unconscious mind. Freud also suggested that ego defense mechanisms are used to keep anxiety at manageable levels. The use of defense mechanisms may result in overuse of behavior that is not wholly adaptive because of its rigidity and repetitive nature. Harry Stack Sullivan believed that anxiety is linked to the emotional distress caused when early needs go unmet or disapproval is experienced. Interpersonal theory. He also suggested that anxiety is contagious, being transmitted to the infant from the mother or caregiver. Thus, the anxiety felt early in life becomes a prototype for anxiety responses when unpleasant events occur later in life. Behavioral theories suggest that anxiety is a learned response to specific environmental stimuli. Classical conditioning. An example of classical conditioning is a boy who is anxious in the presence of his abusive mother. He then generalizes this anxiety as a response to all women. Conditioning can be reversed through the influence of safe and loving female friends and significant others. The social learning model suggests that anxiety is learned through the modeling of parents or peers. For example, a mother who is fearful of thunder and lightning and hides in closets during storms may transmit her anxiety to her children. These children continue to imitate this fearful behavior into adult life. Such individuals can unlearn this behavior by observing others who react normally to a storm by lighting candles and telling stories. Cognitive theorists believe that anxiety disorders are caused by distortions in an individual's thoughts and perceptions. Because individuals with such distortions exaggerate any mistake and believe that they will have catastrophic results, they experience acute anxiety. People who tend to perceive events and situations as being potentially dangerous may be overly responsive, become anxious, or even experience panic attacks. Cultural considerations. Sociocultural variation in symptoms of anxiety disorders has been noted. In some cultures, individuals express anxiety through somatic symptoms, whereas in other cultures, cognitive symptoms predominate. Panic attacks in Latin Americans and Northern Europeans often involve sensations of choking, smothering, numbness or tingling, as well as fear of dying. In other cultural groups, panic attacks involve fear of magic or witchcraft. Social anxiety in Japanese and Korean cultures may relate to beliefs that the individual's blushing, eye contact, or body odor is offensive to others. The Considering Culture box discusses factors relevant to one anxiety disorder, ataque de nervios, primarily experienced by people from Hispanic cultures. Refer to Chapter 5 for more discussion of cultural issues. Application of the nursing process. Assessment. General assessment. People with anxiety and obsessive compulsive disorders rarely need hospitalization unless they are suicidal or have compulsions that cause injury, e.g., cutting self, infected sores from picking. Most of these individuals are encountered incidentally in a variety of community settings. A common example is someone taken to an emergency department to rule out a heart attack, when in fact the individual is experiencing a panic attack. It is essential to determine whether anxiety is the primary problem, as in an anxiety disorder, or secondary to another source, medical condition, or substance. Your assessment should be patient-centered to be helpful or meaningful. First and foremost is the recognition that the patient is the expert when it comes to his or her own illness. Elicit information about what has helped in the past. Identify expectations for the patient's personal participation in care and for the family or significant other's participation in care. Assess for specific cultural, ethnic, and social backgrounds that may impact the care that you and the patient plan. Objectively, there are a variety of scales available to measure anxiety and anxiety-related symptoms, and most are available online. The Yale-Brown Obsessive Compulsive Scale measures severity of compulsive behavior. The Hoarding Scale, self-report, measures hoarding. Phobias are measured on the Fear Questionnaire, and panic symptoms are measured on the Panic Disorder Severity Scale. The severity measure for generalized anxiety disorder in adults is a popular tool for measuring anxiety, figure 15.2. High scores may indicate GAD or panic disorder, although it is important to note that high anxiety scores may also be a symptom of major depressive disorder. Self-assessment. As a nurse working with an individual with an anxiety or OCD, you may have feelings of frustration, especially if it seems that his or her symptoms are a matter of choice or under personal control. The rituals of the patient with OCD may seriously slow your ability to complete certain nursing tasks within the usual time. How do you respond to a person with a phobia who acknowledges that the fear is exaggerated and unrealistic, yet continues to engage in avoidant behavior? Behavioral change is often accomplished slowly. The recovery process is very different from what is seen in physical disorders such as infection. After being given antibiotics, improvement may be seen in as little as 24 hours. Planning outcomes in small attainable steps can help prevent you from feeling overwhelmed by the patient's slow progress and help the patient gain a sense of control. Diagnosis. The North American Nursing Diagnosis Association International provides many nursing diagnoses that can be considered for patients with anxiety and OCD. The related to component will vary with the individual patient. Outcomes identification. The NOC identifies desired outcomes for patients with anxiety-related or OCD. Outcomes are linked with signs and symptoms and nursing diagnosis in Table 15.8. Planning. Whenever possible, the patient should be encouraged to participate actively in planning. By sharing decision-making with the patient, you can increase the likelihood that the treatment regimen will be successful. Owning responsibility for health outcomes improves adherence. Shared planning is especially appropriate for someone with mild or moderate anxiety. When experiencing severe levels of anxiety, the patient may be unable to participate in planning, and the nurse may be required to take a more directive role. Implementation. When working with patients with anxiety and OCDs, you must first determine what level of anxiety they are experiencing. A general framework for anxiety interventions can then be built on a solid foundation. Mild to moderate levels of anxiety. A person experiencing a mild to moderate level of anxiety is still able to solve problems. However, the ability to concentrate decreases as anxiety increases. A patient can be helped to focus and solve problems when you use specific nursing communication techniques, such as asking open-ended questions, giving broad openings, and exploring and seeking clarification. Closing off topics of communication and bringing up irrelevant topics can increase a person's anxiety, making the nurse, not the patient, feel better. Reducing the patient's anxiety level and preventing escalation to more distressing levels can be aided by providing a calm presence, recognizing the anxious person's distress, and being willing to listen. Evaluation of effective past coping mechanisms is also useful. Often, you can help the patient consider alternatives to problem situations and offer activities that may temporarily relieve feelings of inner tension. Table 15.9 identifies interventions useful in assisting people experiencing mild to moderate levels of anxiety. Severe to panic levels of anxiety. A person experiencing a severe to panic level of anxiety is unable to solve problems and may have a poor grasp of what is happening in the environment. Unproductive relief behaviors may take over, and the person may not be in control. Priority nursing interventions are to provide for the safety of the patient and others to meet physical needs, e.g. fluids and rest, to prevent exhaustion. Anxiety reduction measures may take the form of guiding the person to a quiet environment. The use of medications and restraints of seclusion may have to be considered. As always, both medications and restraints should be used only after other, less restrictive interventions have failed to decrease anxiety to safer levels. Because individuals experiencing severe to panic levels of anxiety are unable to solve problems, the techniques suggested for communicating with people with mild to moderate levels of anxiety are not as effective at more severe levels. Patients experiencing severe to panic anxiety levels are out of control, so they need to know that they are safe from their own impulses. Firm, short, and simple statements are useful. Reinforcing commonalities in the environment and pointing out reality when there are distortions can also be useful interventions for severely anxious people. Table 15.10 suggests some basic nursing interventions for patients with severe to panic levels of anxiety. Anxiety management and reduction are primary concerns when working with patients who have anxiety and obsessive compulsive disorders, but they may have a variety of other needs. When developing a plan of care, psychiatric mental health registered nurse can use Psychiatric Mental Health Nursing Scope and Standards of Practice, blah, blah, blah. The Nursing Interventions Classification offers pertinent interventions in the behavioral and safety domains. Refer to box 15.1 for potential nursing interventions for patients experiencing anxiety. They could really jazz this up a bit. Guidelines for basic nursing interventions are 1. Use counseling, milieu therapy, promotion of self-care activities, and psychobiological and health teaching interventions as appropriate. 2. Guide patients through slow, deep breathing exercises, along with progressive muscle relaxation. 3. Identify community resources that can offer the patient specialized treatment proven to be highly effective for people with a variety of anxiety disorders. 4. Identify community support groups for people with specific anxiety disorders and their family. Counseling. Basic level psychiatric mental health registered nurses use counseling to reduce anxiety, enhance coping and communication skills, and intervene in crises. When patients request or prefer to use integrative therapies, the nurse performs assessment and teaching as appropriate. Teamwork and safety. As mentioned earlier, most patients who demonstrate anxiety disorders and OCDs can be treated successfully as outpatients. Hospital admission is necessary only if severe anxiety or compulsive symptoms interfere with the individual's health or if the individual is suicidal. When hospitalization is necessary, the healthcare team can be especially effective by collaborating to develop a multidisciplinary treatment plan to address goals, interventions, and outcomes that include the patient's input, evaluating and refining the plan of care at regular intervals, documenting the plan and other essential communication electronically through an interactive and secure system, identifying specific members of the treatment team to be responsible for carrying out specific actions of the plan, maximizing safety through the provision of calm and consistent care, stressing the value of unconditional positive regard, maintaining a safe environment with an atmosphere of low-level stimulation, providing ongoing education and training for the team to recognize escalating or problematic behaviors, promotion of self-care activities, respecting the patient's preferences for how involved they are in self-care while recognizing that they may require more or less guidance depending on their level of ability is a fine balance. Including the patient in care decisions is essential whenever possible. Patients with anxiety and obsessive compulsive disorders are usually able to meet their own basic physical needs. Self-care activities that are most likely to be affected are discussed in the following sections. Nutrition and fluid intake. Patients with high levels of anxiety are not focused on eating and drinking. Some phobic patients may be so afraid of germs that they cannot eat. In home settings, individuals who hoard may have created an environment that is so dysfunctional that normal intake may be impossible. Likewise, people who engage in ritualistic behaviors may be too involved with their rituals to take time to eat and drink. In general, nutritious diets with snacks should be provided. Adequate intake should be firmly encouraged, but power struggles should be avoided. Weighing patients frequently, e.g. 3 times a week, is useful in assessing nutrition. Personal hygiene and grooming. Some patients with anxiety and OCDs are indecisive about bathing or about what clothing should be worn. For the latter, limiting choices to 2 outfits is helpful. In the event of severe indecisiveness, simply presenting the patient with the clothing to be worn may be necessary. You may also need to remain with the patient to give simple directions. Put on your shirt. Now put on your slacks. Matter-of-fact support is effective in assisting patients to independently perform as much of the task as possible. Encourage patients to express thoughts and feelings about self-care. This communication can provide a basis for future health teaching or for ongoing dialogue about the patient's abilities. Some patients, especially those with OCDs and phobias, may be excessively neat and engage in time-consuming rituals associated with bathing and dressing. Hygiene, dressing, and grooming may take several hours. Maintenance of skin integrity may become a problem when the rituals involve excessive washing and skin becomes excoriated and infected. Assessment of skin integrity is also a concern for individuals who pull their hair or pick at their skin. Elimination. Patients with severe OCD may be so involved with the performance of rituals that they may suppress the urge to void and defecate. Urinary tract infections and constipation may result. Interventions may include creating a regular schedule for taking the patient to the bathroom. Sleep. Patients experiencing anxiety and OCDs frequently have difficulty sleeping, particularly in falling asleep. Patients with GAD often experience sleep disturbance from nightmares. Separation anxiety disorder may have such profound fears that sleep seems impossible. Patients may perform rituals to the exclusion of resting and sleeping, and physical exhaustion may occur. Teaching patients how to discover ways to promote sleep, e.g. warm bath, warm milk, and relaxing music, and monitoring sleep through a sleep record are useful interventions. Chapter 19 offers an in-depth discussion of sleep disturbances. Pharmacological interventions. Several classes of medications have been found to be effective in the treatment of anxiety disorders. Table 15.11 identifies medications approved by the U.S. FDA for the treatment of anxiety disorders. Refer to Chapter 3 for a more detailed explanation of the actions of psychotropic medications. Antidepressants. SSRIs are considered the first line of defense in most anxiety and OCD-related disorders. These SSRIs include paroxetine, Paxil, fluoxetine, Prozac, escitalopram, Lexapro, fluvoxamine, Luvox, and sertraline, Zoloft. Some of these antidepressants exert more of an activating effect than others and may actually increase anxiety initially. Fluoxetine and sertraline tend to be the most activating. Paroxetine seems to have a more calming effect than the other SSRIs. Antidepressants have a secondary benefit of treating comorbid depressive disorders. Venlafaxine, Effexor, is a serotonin norepinephrine reuptake inhibitor that is quite successful in the treatment of several anxiety disorders. Another SNRI, duloxetine or Cymbalta, is effective in the treatment of GAD. MAOIs are reserved for treatment-resistant conditions because of the risk of life-threatening hypertensive crisis if the patient does not follow dietary restrictions. Patient cannot eat food containing tyramine and must be given specific dietary instructions. The risk of hypertensive crisis also makes the use of MAOIs contraindicated patients with comorbid substance use disorders. See Chapter 14 for a full discussion of antidepressants. Anti-anxiety drugs. Anti-anxiety drugs are often used to treat the somatic and psychological symptoms of anxiety disorders. When moderate or severe anxiety is reduced, patients are better able to participate in treatment of their underlying problems. Benzodiazepines are most commonly used because they have a quick onset of action. However, due to the potential for dependence, these medications should be used for short periods only until other medications or treatments reduce symptoms. An important nursing intervention is to monitor for side effects of the benzos, including sedation, ataxia, and decreased cognitive function. Paradoxical reactions, reactions that are the exact opposite of intended responses, sometimes occur. Symptoms such as anxiety, agitation, talkativeness, and loss of impulse control may occur when using this classification of meds. Benzos are not recommended for patients with a substance use disorder. They are not recommended for elderly patients due to a risk of delirium, falls, and fractures. The decision to use benzos during pregnancy should be made by weighing the risk of fetal exposure versus the risk of untreated anxiety. Benzo use shortly before delivery can result in a dystonia and muscle weakness in the newborn known as floppy infant syndrome. Withdrawal symptoms in the neonate have been known to occur. Prenatal benzo exposure increases the risk of oral cleft lip and palate, although the absolute risk increases only by 0.01%. The FDA warns against breastfeeding while taking these drugs since they pass into breast milk. Box 15.2 summarizes important information for patient teaching. Box 15.2, caution the patient not to change dose or frequency of meds without consultation with the prescriber. These medications may make it unsafe to handle mechanical equipment, like cars, saws, and machinery. Avoid alcoholic beverages and other anxiety drugs due to unsafe depressant effects when combined. Avoid drinking beverages containing caffeine because they decrease the desired effects of the drug. Review prescription medications and doses that may cause or increase anxiety, e.g. thyroid hormone, steroids, decongestants. 2. Discuss the risk to the fetus and the risk of untreated anxiety disorders with prescribers should pregnancy occur or to be considered. 3. Advise the patient to discuss breastfeeding with prescriber because these drugs are excreted in the milk could have adverse effects on the infant. 4. Teach a patient who is taking MAOIs about the details of a tyramine-restricted diet. 5. Teach the patient that cessation of benzo use after 3 to 4 months of daily use may cause withdrawal, such as insomnia, irritability, nervousness, dry mouth, tremors, convulsions, and confusion. Medications should be taken with or shortly after meals or snacks to reduce GI discomfort. Drug interactions can occur. Antacids may delay absorption. Cimetidine interferes with metabolism of benzos, causing increased sedation. CNS depressants such as alcohol and barbiturates cause increased sedation. Where was I at? Oh yeah. Buspirone, or Buspar, is an alternative anti-anxiety medication that does not cause dependence, but 2 to 4 weeks are required for it to reach full effects. The drug may be used for long-term treatment and should be taken regularly. Side effects include dizziness, nausea, headache, nervousness, lightheadedness, and excitement. Buspirone is not recommended for individuals with impaired hepatic or renal function, since an increased plasma levels and lengthened half-life may result. There is no direct evidence that this medication poses a danger to the developing infant. The FDA recommends using the drug during pregnancy and breastfeeding only if clearly necessary. Other classes of meds. Other classes of meds sometimes used to treat anxiety disorder include beta blockers, antihistamines, anticonvulsants, and antipsychotics. These agents are often added if the first course of treatment is ineffective. Beta blockers block the receptors that, when stimulated, cause the heart to beat faster. The beta blockers reduce physical manifestations of anxiety by slowing the heart rate and reducing blushing, and have been used to treat social anxiety disorder. Anticonvulsants have shown some benefit in the management of GAD and SAD. Gabapentin, or Neurontin, and pregabalin, or Lyrica, for example, are commonly prescribed. Antihistamines are a safe, non-addictive alternative to benzos to lower anxiety levels and again are helpful in treating patients with substance use problems. Antipsychotic medications are useful in treating more severe symptoms of anxiety disorders. There are no FDA-approved drugs for the treatment of the following disorders: separation anxiety, specific phobia, body dysmorphic, hoarding, trichotillomania, and excoriation. Despite the lack of approval, these conditions are often treated with antidepressants, anti-anxiety agents, and the other classes of medications previously described. Wow, that's great. Pharmacological interventions in children and adolescents. You know what? We're not going to read that because this isn't PEDS. Psychobiological interventions. Besides medication, there are a few biological interventions available to disrupt the course of anxiety and anxiety-related disorders. Surgery has been used in OCD for the more severely affected. A gamma knife creates irreversible damage known as lesions to certain area of the brain, resulting in a disconnect of overactive circuits or regions. A relatively new reversible surgical treatment being used for OCD is deep brain stimulation. This technique is considered a valid treatment. Electrodes are surgically placed in the subthalamic nucleus of the brain. Then an implanted pulse generator in the chest activates a low-dose current for a specified period of time, several months in some cases. Researchers have reported a decrease of 35% on a measurement of OC symptoms. Complementary and integrative therapy. Chapter 35 identifies a number of complementary practices or integrative therapies that people use to cope with stress in their lives. Herbal therapy and dietary supplements are commonly used, yet they are not subject to the same rigorous testing as prescription medications. Also, herbs and dietary supplements may not be uniformly prepped or dosed, and there is no guarantee of bioequivalence of the active compound among preparations. Problems that can occur with the use of psychotropic herbs include toxic side effects and herb-drug interactions. Nurses and other healthcare providers should stay current regarding these popular products in order to assist their patients in making informed decisions. One example is kava, which is derived from the roots of Piper methysticum, a South American plant. Kava is used as a sedative with anti-anxiety effects. As an alternative to seeking professional care, people with anxiety disorders may try kava in the belief that herbs are safer than medications, but it has a dark side. In 2010, the FDA issued a warning regarding its risk for liver damage. Kava is known to dramatically inhibit the P450 liver enzyme necessary for the metabolism of many medications. This inhibition could result in liver failure, especially when taken with alcohol or other medications, such as CNS depressants. Health teaching. Health teaching is a significant nursing intervention for patients with anxiety disorders. Patients may conceal symptoms for years before seeking treatment and often come to the attention of healthcare providers during a co-occurring problem. People with panic disorders and GAD seem more motivated than those with other anxiety disorders to get treatment. Most seek help during the first year of symptoms. Teaching about the specific disorder and available effective treatments is a major step towards improving the quality of life for those with anxiety disorders. Whether in a community or hospital setting, nurses can teach patients about signs and symptoms of anxiety disorders. Presumed causes or risk factors, especially substance abuse, medications, the use of relaxation techniques, and the benefits of psychotherapy. Relaxation exercises for breathing or muscle groups are extremely useful in initiating a relaxation response. The relaxation response is the opposite of the stress response and results in a reduced heart rate and breathing and relaxed muscles. Advanced practice interventions. Psychiatric mental health advanced practice registered nurses use evidence-based cognitive treatment approaches. Behavioral approaches such as modeling, systematic desensitization, flooding, response prevention, and thought stopping are also useful with the anxiety and OCDs. CBT link both of these approaches. Cognitive therapy is based on the belief that patients make errors in thinking that lead to mistaken negative beliefs about self and others. For example, I have to be perfect or my boyfriend will not love me. Through a process called cognitive restructuring, the therapist helps the patient 1. Identify automatic negative beliefs that cause anxiety, 2. Explore the basis for these thoughts, 3. Reevaluate the situation realistically, and 4. Replace negative self-talk with supportive ideas. Behavioral therapy. There are currently several forms of behavioral therapy which involve teaching and physical practice of activities to decrease anxious or avoidant behavior. Modeling. The therapist or significant other acts as a role model to demonstrate appropriate behavior in a feared situation, and then the patient imitates it. For example, the role model rides in an elevator with a claustrophobic patient. Systemic desensitization. The patient is gradually introduced to a feared object or experience through a series of steps, from the least frightening to the most frightening, graduated exposure. The patient is taught to use a relaxation technique at each step when anxiety becomes overwhelming. For example, a patient with agoraphobia would start with opening the door to the house to go out on steps and advance to attending a movie in a theater. The therapist may start with imagined situations in the office before moving on to in vivo or live exposures. Flooding. Unlike systemic desensitization, this method exposes the patient to a large amount of an undesirable stimulus in an effort to extinguish the anxiety response. The patient learns through prolonged exposure that survival is possible and that anxiety diminishes spontaneously. For example, an obsessive patient who usually touches objects with a paper towel may be forced to touch objects with a bare hand for 1 hour. By the end of that period, the anxiety level is lower. Response prevention. This method is used for compulsive behavior. The therapist does not allow the patient to perform the compulsive ritual, e.g. hand washing. The patient learns that anxiety does subside even when the ritual is not completed. After trying this in the office, the patient learns to set time limits at home to gradually lengthen the time between rituals till the urge fades away. Thought stopping. Through this technique, a negative thought or obsession is interrupted. The patient may be instructed to say, "Stop," out loud when the idea comes to mind, or to snap a rubber band worn on the wrist. This distraction briefly blocks the automatic undesirable thought and cues the patient to select an alternative, more positive idea. After learning the exercise, the patient gives the command silently. CBT. CBT combines cognitive therapy with specific behavioral therapies to reduce the anxiety response. CBT includes cognitive restructuring, psychoeducation, breath restraining, and muscle relaxation, teaching of self-monitoring for panic and other symptoms, and real-life exposure to feared objects or situations. Evaluation. Identified outcomes serve as a basis for evaluation. In general, evaluation of outcomes of patients with anxiety and OCDs deals with questions such as the following. Is the patient experiencing a reduced level of anxiety? Does the patient recognize symptoms as anxiety-related? Does the patient continue to display signs and symptoms such as obsessions, compulsions, phobias, worrying, or other symptoms of anxiety disorders? If still present, are they more or less frequent, more or less intense? Is the patient able to use new behaviors to manage anxiety? Does the patient adequately perform self-care activities? Can the patient maintain satisfying interpersonal relationships? Is the patient able to assume usual roles? Quality improvement. Quality improvement attempts to quantitatively measure severity of disorders, develop outcomes and guidelines for care, and monitor a patient's progress. In primary care, where most people seek mental health care, evidence-based practice guidelines result in practitioners being more confident in their skills and more likely to treat anxiety. Evidence-based treatment includes using CBT, prescribing appropriate medication, and following up with patients. Primary care providers may need expert support to provide this care. A variety of instruments are used in quality improvement initiatives for psychiatric disorders. A simple tool for measuring quality improvement for anxiety care is the Clinical Global Impression Severity Scale for inpatient, outpatient, or primary care. It asks the clinician to rate the severity of illness on a 7-point continuum from normal, not ill, to among the most extremely ill. Versteeg and colleagues developed the following outcomes for use with this tool. At least 80% of patients with anxiety disorders are monitored every 6 weeks with the CGI-S scale. After 6 months of treatment, 50% of patients with severe anxiety disorders will score less than 3 on the CGI-S. Nurses are at the forefront in gathering information to improve the quality of care in all settings. Understanding anxiety disorders and their treatment is more accomplished when we consider the seriousness and importance of continuous quality improvement in providing care. And that is all for anxiety and OCDs.